On the application slide. पण ढेंगळे माझ्या लॅपटॉपवर आलं नाही अजून. PBL आणि चव्हाण असं नाव आहे.
बस करू का?
Today we will discuss a case related to the gradual progressive painless loss of So today we will discuss about the case in which there is a gradual progressive painless loss of vision. Some technical problem. So today we will discuss about the case in which there is a gradual progressive painless loss of vision. याचं पुढे पण कसं age-related macular degeneration, then optic atrophy, diabetic retinopathy, retinitis pigmentosa. So these are the causes for gradual progressive loss of vision in a patient above 65 years of age. Age-related macular degeneration, then optic atrophy, diabetic retinopathy, retinitis pigmentosa. Then how will you proceed for such? Means what is the cause of gradual progressive loss of vision? So we have to take the history of the patient, detailed history of the patient. Then we have to do the general examination and then local examination. So in general examination, the 65 years patient whose built is well built, nourished, per 66 minutes, blood pressure 140/80. This examination is done with under heading of general examination. So everything was normal. Then on a local examination, leads surrounding adnexa means lacrimal sac, lacrimal area also normal. Digital intraocular pressure was normal. So these rule out the means of cause for the glaucoma. Then conjunctival, that is a normal, no congestion. Cornea means size, shape, transparency, that is normal. Entry chamber depth, which is also normal. There is no abnormal content in the entry chamber like blood or any other foreign body. Then iris is having normal color pattern. Pupil circular and briskly reacting to the light. Iris shadow is seen, and dark opacity are seen against the red fundus glow. So how will you differentiate these causes? So common causes for the gradual progressive loss of vision we have seen first is the cataract. So in cataract, there will be white reflex in the pupillar area, and if there is iris shadow, we label it as a immature cataract. If there is no iris shadow, we label it as a mature cataract. Then age-related macular degeneration, in which we will see that there is no white reflex which will cause the such vision, means our vision may be there is a great loss. So that age-related macular degeneration may be the cause, means there is no cataract but still there is a loss of vision. Then we have to see the fundus, and in fundus you will see that in macula there are drusense, or there are types of age-related macular degeneration like wet ARMD and dry ARMD. Means in wet ARMD there is a neovascularization in the macular area, while in dry ARMD there are just drusense in the macular area. So anyhow, any age-related macular degeneration, there will be gradual progressive painless loss of vision, and this is a very common cause in European countries or developed countries for the loss of vision. So by fundus you can differentiate that from cataract. Then optic atrophy. In optic atrophy you will see that on fundus examination the color of the disc is pale. Then if it is a primary optic atrophy, the color of disc is chalky white, and if it is a secondary optic atrophy in fundus, there might be some lesion which is responsible for the optic atrophy. So we can differentiate from other causes like ARMD and cataract, the optic atrophy. Diabetic retinopathy, patient may have a history of diabetes, and at least 10 years are required to develop the diabetic retinopathy. So patient will give a history of diabetes, and again there are findings of diabetic retinopathy like heart exudate or these hemorrhages, then dilatation of the veins. So such findings of diabetic retinopathy will be there. By that you can diagnose that what is the cause for the gradual progressive loss of vision. So these are generally common causes for this gradual progressive painless loss of vision. Even in retinitis pigmentosa also there can be a gradual progressive loss of vision. So in this, again fundus, you will see the bony corpuscles, they are arranged, then patient will complaining of night blindness. So such symptoms will be there. So by all this, you can rule out the case, or you can come to a diagnosis whether this gradual, progressive, painless loss of vision is due to what cause. So in the examination also, for especially for that question, for 2 marks, question is asked, write the 4 causes of gradual, progressive, painless of vision. In that you can write then this senile cataract, then open angle glaucoma, or diabetic retinopathy, retinitis pigmentosa, or ARMD, or optic atrophy. So in this way. So by this you can differentiate. Now most common cause is cataract, senile cataract. So we will discuss about this senile cataract. So fundus examination by direct ophthalmoscope in cataract, fundus will be normal. So no other findings like diabetic retinopathy or retinitis pigmentosa or optic atrophy. So your diagnosis mostly it is a cataract responsible for the gradual, progressive, painless loss of vision. Now what is the treatment? How to manage a case of immature senile cataract? So when you will advise surgery to the patient of the cataract, generally when patient's routine activities are disturbed, we advise cataract surgery to the patient. Again, it depends upon patient also. If patient is, suppose there are 2 patients, one patient is having 6 patient, both the patient are having vision 624, but one patient is housewife and another is jeep driver. So a patient means by occupation jeep driver having vision 624, and a patient housewife having 624 vision. So in driver you have to advise the surgery, but in housewife you can postpone or you can advise by some days or months you can undergo the surgery. But immediately in the jeep driver or driver you have to advise the surgery. So whether the patient's routine is disturbed or not, depending upon that we advise surgery. If mature cataract, anyhow, irrespective of the occupation of the patient, you have to advise the surgery. So in immature senile cataract, depending upon the patient's requirement, we advise the surgery. Now suppose we want to do the surgery in this patient, then how we have to proceed? So for that we have to do some pre-operative investigations. By that investigations we'll come to know whether patient is fit for the surgery or not. And this investigations are local investigation and systemic investigation. In systemic investigation, what we do? Blood investigations. In blood investigation, like all these basic investigations like hemoglobin, then TLC, DLC, ESR, hemoglobin. Means hemoglobin is important. Why? Because if hemoglobin is less than 7, generally we don't operate. We refer the patient to the medicine, or we advise him to take some iron preparation by which hemoglobin is increased. Why less hemoglobin? If there is hemoglobin is less, we don't operate, because such patients are prone for the infection. So better to advise. Cataract surgery is not a life-saving surgery. So any doubt or some problem is there, you can postpone the surgery for some time. So for hemoglobin also, when hemoglobin is above 8, then you can advise surgery. So hemoglobin is important investigation. Then TLC, DLC, it gives a general idea or general fitness of the patient. If there is a TLC, there is a more total leukocyte count. It indicates that there is some infection, inflammation in the body or some ESR is red. So some problem is there. We can conclude and we can refer the patient to the medicine department and ask him to find out what is the cause for this TLC, raised TLC or ESR. So in this way This gives this basic investigation gives general idea about the general fitness of the patient. So basic investigation like hemoglobin, TLC, DLC, ESR, and then important investigation blood sugar. Blood sugar is very important investigation whenever you are creating some wound over the patient's body, because you know in diabetic wound healing is delayed. That's why we should not operate patient whose blood sugar is high. Generally blood sugar, fasting blood sugar below 120, we can operate such patient, but if it is above 120 we have to first think about the control of the blood sugar and then we can operate. So blood sugar is very important investigation. Then other investigations like renal function test. It is also important renal function test because these people are old patient and they may suffer from chronic hypertension, chronic renal failure, and such patient may have problem while giving block or in OT. So better to correct this dysfunction of the kidney and then take the patient for the OT, advise the surgery. So renal function test like the serum sodium, potassium serum or blood urea you have to advise. The liver function tests are not much important, but still you can advise for the general fitness. But renal function tests are very important because these are old patient, chronic hypertension, chronic renal failure can be there. Then chest X-ray also, if there is some infection in the chest, so it will be detected by chest X-ray. And nowadays, as this is a epidemic of this this corona, that's why chest X-ray is again very important. So all these basic and some other investigations like HIV and that SBSAG, that are also important because they are transferred due to the blood to blood contact. That's why these are important. So if a patient is HIV, then we don't postpone the patient surgery of the patient, but we have to take some precautions while operating the patient. Like if patient is HIV positive, then you have to take the patient last. If there are 4 to 5 patients for the OT on that day, you can operate this patient in the last number. Or then you have to also take the precautions, wear proper gown, goggle. There is a special kit available for this this HIV patient that you have to use. Then same with HBsAg, hepatitis B, you have to rule out because you know again this disease also transferred by blood to blood contact. So for precaution to avoid this transmission of the disease, we have to also investigate this HIV and HBsAg for the hepatitis B. So all these investigations are important. So these are the systemic investigation. Then which are the local investigation? These are sac syringing, then recording of intraocular pressure, and then recording of the IOL power of the patient. So why sac syringing? Sac syringing already you might have seen during your clinical posting how sac syringing is done. You know there are 2 openings in the lid, in upper eyelid and lower eyelid, and these are punctum. Through that punctum we push saline by the sac syringing cannula saline. So if that saline comes in the throat, means these lacrimal passages are patent, and then means lacrimal passages are functioning. So it rule out the chronic dacryocystitis. We do the regurgitation test, but many times there can be false negative regurgitation test because patient may have just evacuated the sac before your sac syringing, or there may be internal fistula. So by that also the sac syringing can be negative. But if there is a sac syringing, with sac syringing there is some mucoid discharge, then you have to postpone the surgery, because if there is a chronic dacryocystitis, one thing there should be no focus of infection in the body while surgery. No focus in the body, even nose, throat, surrounding area, ear, or caries tooth, or anywhere. That's why sac syringe. Chronic dacryocystitis also, if there is chronic dacryocystitis, then first you have to treat the chronic dacryocystitis, and then you can think about the cataract surgery. Because if there is a dacryocystitis and you are operating, there will be a constant source of infection, and there is a chances of endophthalmitis. Same with lead infection also, that you cannot operate. If there is a stye, you cannot operate the patient, because that stye also in constant contact the wound that you create for the cataract surgery. So there should be no focus of infection in the body at the time of surgery. So sac syringing important. Then intraocular pressure. During the local examination, you have seen the intraocular pressure by digitally. But digitally, sometimes there can be a misjudgment, and we cannot have correct idea about the intraocular pressure. If intraocular pressure is high and you are operating for the cataract, there is chance of expulsive choroidal hemorrhage. And you know the treatment of the expulsive choroidal hemorrhage, this evisceration. So patient is coming for the vision and you are doing evisceration, that is not good. That's why intraocular pressure should be normal at the time of surgery. Then you have to calculate the IOL power. IOL power, for that for that axial length of the eyeball, which is known by A scan, and then you have to do the keratometry, and you have to feed this reading to the machine. Automatically you will get the IOL power, because you are implanting the lens which is required for the patient. Any lens you cannot implant, which is, some patients are myopic, according to them IOL power will be different. If they are hypermetropic, IOL power will be different. That's why the IOL power which is required for the patient is calculated, and that particular lens is, the particular IOL of that power is implanted. So pre-operative investigations are very important. Then if all these pre-operative investigations are normal, then you can advise surgery to the patient. So when surgery is advised, if patient is willing, you can go. Means for that you have to take the consent of the patient. If patient is not ready for the surgery, even though investigations are normal, then what is the use? So informed written consent. I know, and I hope that you are knowing the meaning of informed written consent. Inform means you have to explain what is the surgery, what complications can occur. All this you have to explain about the surgery to the patient, and then in his own handwriting. If patient is illiterate, in the handwriting of relatives, you can take the consent. Then after obtaining the consent of the patient, then you have to prepare the eye of the patient for the surgery. So these things include in the preparation, these are the trimming of the eyelashes. You have to trim the eyelashes because these eyelashes will come in the surgical field and can disturb. That's why better to trim the eyelashes. Many surgeons they don't trim the eyelashes, but it depends upon the surgeon. But better to trim, because your surgical field will be open, will be free. Then you have to do the xylocaine sensitivity test. Many times, means xylocaine means reaction to the xylocaines are known. Reaction to the anaphylactic reaction to the xylocaine is known. So that's why better to do the skin sensitivity test with the xylocaine. So where you can relax, but there is no reaction to the patient. Even you can ask to the history of the patient also, and according to that you can do the xylocaine sensitivity test. So if xylocaine test no problem, then you can, before you can advise patient before 2 hours before the surgery, take the head bath, and that is from head, because after surgery patient can take the bath but not from the head. Head bath is not allowed after the surgery for 1 month. So ask the patient take head bath. It is good for hygienic point of view also. So take the head bath with face wash, because many times patient they are having poor hygiene, so that will be clean with this head bath and well face wash. Then after the bath and the patient, then you have to dilate the pupil. For the cataract surgery, you have to dilate the pupil. So for dilatation, you can use homeotropine, tropicamide. These drops are used. Then also you have to add the FLUR drops, non-steroid anti-inflammatory, because they prevent the intraoperative miosis. During surgery, what is happening? You are constantly touching to the iris, and as you touch the iris, pupil will constrict. So to avoid this intraoperative miosis, better to add non-steroid anti-inflammatory like FLUR while dilating the pupil. So well dilated pupil is required for good surgery. If pupil is not dilated, surgery become difficult. How? Means it is difficult to, if you are doing ECC or SICS, difficult to prolapse the nucleus in the antechamber, or difficult to clean the cortical matter, because that cortical matter will be hidden by the iris, and it will not visualize to the surgeon. That's why better to dilate the pupil means as much as possible. Then patient can be shifted to the OT. Before OT also, patient is asked to go for the urination also, because these are old patients. They are having prostate problems. Their frequency of micturition is more. On the table, patient may ask for the this micturition or toilet. So better to ask the patient before shifting to the OT, go for the toilet or urine. So then patient is shifted to the operation theatre. So you know all these generally of all our ocular surgeries, they are done under the local anesthesia. So in local anesthesia, we give the peribulbar block. You know, in peribulbar block, the injections are given in the lower fornix and upper fornix. In lower fornix, 3 ml are given, and where the site? At the junction of medial 2/3 and lateral 1/3. In the lower fornix, what is the site for the injection? Medial 2/3 and lateral 1/3. So in the lower fornix, you can inject the 3 ml solution. And what this solution contains? It contains 2% xylocaine with adrenaline with hyaluronidase. If patient is hypertensive, then plain xylocaine or lignocaine is used, adrenaline is not used. So what are the importance of this? All this you are knowing. The adrenaline, which causes means bleeding is avoided, then hyaluronidase absorption is increase of this solution. So all these elements help have a good anesthesia or good peribulbar block. So how will you come to know that there is a peribulbar block? Ask the patient to look upward, downward, on the side, and if there are no movements, means there is a block, and then you can proceed for the surgery. So it indicates the complete anesthesia is there. Now surgery. So after block is attained, then you can put some 5% betadine in the eye. This 5% betadine is very helpful because it clean the surface microorganisms, make the surface area sterile. So due to the use of 5% betadine, this incidence of endophthalmitis is decreased to a large extent. So putting a betadine eye drop before surgery is very helpful. Then painting, draping, and first painting is done with the 10% betadine again surface sterilization, and then drapes are put over the eye. That eye towel and all these are kept. And then steps you are knowing that you have to take the superior rectus suture, then conjunctival flap, then you have to do the capsulotomy. In capsulotomy also there are like this curvilinear linear capsulorhexis or can opener. So according to the patient of the disease of the surgeon, capsulotomy is done. And then which type of surgery? If you are doing SICs, then incision of 5 to 7 millimeter. If you are doing ECC, then incision at the limbus is taken, that is of 10 to 12 millimeter. And for phaco, just 1.5 to 3 millimeter incision is sufficient. So depending upon which surgery you are doing, you have to take the incision. And then in ECC, SICs, we remove the nucleus, while in phaco we break the nucleus inside the eye only, because incision is so small, just below less than 3 mm, then a nucleus of 5 mm cannot come through this incision. That's why we have to break the nucleus inside the antechamber only, means in the eye only, and then pieces are absorbed by this phaco probe. Means cutting and both the functions are done by this phaco probe. So surgery mainly nowadays, you know that we are doing extracapsular cataract surgery, and these are three surgeries you are knowing. That simple ECC, in which just I told the incision is taken near about 10 to 12 millimeter, that too again at the limbus, while small incision in this incision is again 5 to 7 and phaco 3. So these are the extracapsular cataract surgery nowadays. Then intracapsular cataract surgery is now outdated. Only if a lens is dislocated, then and then only this intracapsular surgery is done. Otherwise, only extracapsular cataract surgery. So while doing the surgery, what intraoperative complications can occur? So globe perforation. When globe perforation can occur? While giving periorbital block. Many times if needle is direct toward the globe, and if patient is myopic, in myopic you know the sclera is very thin. So in such cases, in such patient, chances of globe perforations are there. So with proper precaution, such complication can be avoided. Again, globe perforation can occur at the time of the superior rectus suture. While taking the superior rectus suture globe, the incidence of such perforations is very less. With proper precaution, such complications cannot occur. Then there can also be if your block is slightly retrobulbar, is behind the globe, then retrobulbar hemorrhage also can occur. And in such case, retrobulbar hemorrhage, you have to postpone the surgery, because eyeball become tense like a stony hard. IPS also increase, subsequently hemorrhage. So give the acetazolamide or mannitol and postpone the surgery for the 10 to 15 days. Retrobulbar hemorrhage. Then while doing the surgery, you know, in surgery you have to in extracapsular cataract surgery, you have to, what is the difference between intra and extra? In intra we are taking the lens, whole lens, but in extracapsular cataract surgery we are keeping posterior capsule intact and remaining structures are taken out. So posterior capsule is kept intact in extracapsular surgery. So many times what happens during nucleus delivery or while cleaning the cortical matter, this posterior capsule can be ruptured. There can be tear in the posterior capsule. And when there is a tear in posterior capsule, there is a vitreous behind the posterior capsule that will come into the anterior chamber, and your surgery is now disturbed. Your steps are now disturbed. Vitreous loss, you have to do the vitrectomy. Then if possible, you can do the IOL implantation, or otherwise you can postpone IOL, just do the vitrectomy and leave the patient for the secondary IOL. So after inflammation is reduced, eyeball is settled, eye become quiet, then secondary IOL can be done in such patient. So vitreous loss due to the posterior capsule rupture is means changes the surgical steps. Then if their posterior capsule rupture is a big and surgeon not detected earlier and he is doing some manipulation with the nucleus will go behind the vitreous. What we call is a nucleus drop. Nucleus will go in the vitreous. Then again steps are changed. Some generally nucleus, if there is a nucleus drops, you have to take the nucleus, and especially vitreoretinal surgeons, they are expert in removing the nucleus. You have to remove the nucleus because later on there can be inflammatory reaction, there can be glaucoma. That's why you have to remove the nucleus and then you can do the secondary IOL. Or then can be expulsive hemorrhage. Just I told that if there is a high blood pressure or there is high intraocular pressure and you are operating such patient, there is a chance of rupture of choroidal vessels and there is expulsive choroidal hemorrhage. All content of the eyeball will come out automatically and there so evisceration, auto evisceration occur and patient loses his vision. So expulsive hemorrhage also is a very dangerous complication. So you have to take the proper precaution. You have to avoid expulsive choroidal hemorrhage. So in this way surgery is done, means nucleus is taken out or it is a broken out, IOL is implanted. Then in SICS or phaco sutures are required. In a simple ECC you have to take the 5 sutures, then pad and patient can be sent to the ward. Nowadays the cataract is a day care. It is a day care, means patient is admitted just for 2 to 3 hours. Patient comes in a hospital 1 hour prior to the surgery, then he remains for as hospitalization for 2 hours and then patient is discharged because incision is so small, just like less than 3 millimeter. So it is such a micro incision, so as good as no wound is there, so patient can be discharged. But in our case we keep the patient for 2 days, so then patient can be shifted to the ward. So on that day patient can lie in the bed quietly for 2 hours and then after 2 hours he can sit down, means can raise from the bed, but for 2 hours he should lie in the bed. Then he can take his lunch or he can take his food and can be free. And preoperative also we advise generally a light breakfast can be taken 2 hours before the surgery. So on that day this is the managed. But on second day, if day care surgeon calls the patient to hospital again, and in our management we open the pad and see about the any problem in the eye. So you have to see about the condition of the eye. So what you have to see means you have to see the any early complications whether occur or not. Is there any early complications? So what are the early complications? Early complications: corneal edema, iris prolapse, endophthalmitis, or shallow anterior chamber. If there are such complications or not, that you have to see. If anterior chamber is normal, iris pupil is circular, anterior chamber is maintained, wound is also very close, cornea is clear, then you can discharge the patient and ask the patient for you after 8 days. But in that day he has to put the steroid antibiotic drops 6 times for first week. Then if there are some complication, early complication, if there is iris prolapse, then if there is iris prolapse, again you have to take the patient for in the OT If iris prolapse is very small, then you can put pilocarpine drop. Pilocarpine will constrict the pupil and iris will be pulled inside. But many times this don't happen. Then you have to take the patient in operation theatre. You have to reposit that iris and then take the suture. If corneal edema, again you have to prescribe some hyperosmotic agent by which the water content of the cornea will be extracted. So corneal edema can be due to the damage to the endothelium, or it may be due to the rise in intraocular pressure. So if there is a rise in intraocular pressure, you can see digitally, then you have to give the drugs which lower the intraocular pressure, like timolol or acetazolamide you can give and bring the IOP down, then corneal edema will be relieved. Or there can be hyphema, that is blood in antechamber. Again, spontaneously it will be get absorbed, the hyphema. But if it is a more means full chamber, then again your paracentesis may be required, means opening from the side port and wash the that blood. Or antechamber can be shallow. Antechamber can be shallow due to the wound leak. That wound leak you can diagnose by there's a fluorescent test, putting fluorescent. If there is a dilution of drug, then you can think that there is wound leak, and then again you have to take the patient in OT, take the suture, close the wound. Or there can be choroidal detachment. No special treatment is required. Pressure pad bandage is required for that choroidal detachment, and antechamber will be formed. Then endophthalmitis is a very danger complication which occur early. In that, symptoms are patient is having severe pain, vision, there is no vision, there is a congestion, circumcorneal conjunctival congestion, chemosis, corneal edema, there will be hypopyon, yellow reflex in the pupillary area. All these signs symptoms will be there, severe pain will be there, and then you can diagnose this patient as a endophthalmitis with a danger complication. You have to differentiate another condition like there's a toxic anti-segment syndrome. In that also there is a hypopyon or chemosis also, but there is no pain or loss of vision. So by that you can differentiate. But patient there is endophthalmitis, then B scan is done, and again you have to think whether means intravitreal injections are given or just vitrectomy with intravitreal injections are given. Nowadays prognosis of endophthalmitis is changed, means it is a good due to this intravitreal injections. So you have to give the intravitreal injection like vancomycin or this amikacin. With this endophthalmitis have a good prognosis. Such complication you have to see on the first day, and if no, you can discharge the patient. Then patient is asked to put the steroid antibiotic drops for the 6 weeks. Why 6 weeks? Because wound 6 weeks are required for the healing of the wound, and after healing the wound, the refraction gets settled, and you can advise refraction if required for the patient. Generally, we are putting the lens which is required for the patient. So generally no refraction is required. Even it depends again on the lens. You are putting the multifocal lens. If multifocal lens you are implanted, then no refraction is also required. But for these 6 weeks, patient is there should be a review intermittently. Patient has to come to the doctor for the for any complication occurred or not, or everything is going smoothly or not, that doctor has to see, and patient has to put the steroid antibiotic drops for the 6 weeks. So review in between is required. And again, cataract goggles also patient will wear. He will not travel, so he has to take the proper precaution and put the eye drops regularly. By that everything will then go smoothly and nicely. So this is the management of cataract. So there will be a question for this. So we have discussed the case where patient above 65 years of age having progressive, painless, gradual progressive painless loss of vision. We have seen the causes, and most common cause is senile cataract. And we have discussed the case. So what are the symptoms? How to manage case of cataract. So in this way, it is important from practical point of view. Okay, thank you. Dale.